Hello, my name is Dr. Ukiri Richard. I continue my podcast on basic cardiology. Today we are going to talk about young patient with high fever and diarrhea. Today we are talking about a case where the doctor on call in the emergency room called you for consultation because of a pathologic ECG finding. This resting ECG is actually from a 31-year-old male patient that has been having diarrhea for some days and partially mixed with blood. He just returned from a trip to India when he spent some months. The doctor also told you that this patient is suffering for a high fever gastrointestinal infection and among other things, a Shigella infection is under suspicion. You looked at the ECG and the 12-channel ECG and you saw a regular sinus rhythm, left azics 96 per minute with a wide, broad QRS complex in V1 to V3 that had significant repolarization disturbances. Just that I cannot tell you the polarization disturbance you have here is an ST elevation from a deep Q that actually ends in negative T wave in V1 and V2, maybe V3. So my question is, what diagnosis are you suspecting and what are you going to do? My suspected diagnosis here is Brugada syndrome. Typical findings in Brugada syndrome are: 1. A spontaneous coved coved or gevobte ST segment elevation type 1 in more than one right precordial breast leads as V1 to V3 and one of the following criteria: a documented ventricular fibrillation, a self-limiting polymorphic ventricular tachycardia, sudden heart death in relations under 45 years of age, type 1 ECG in relations less than 41 years of age, a syncope, a reproducible ventricular arrhythmia in electrophysiologic examination, and unclear syncope where you suspect a rhythmogenic cause. So those are the typical findings of Brugada syndrome. Now, spontaneous coved SC segment with any of those. Another typical finding, you can have an ST segment elevation type 2 or type 3 that can be converted through administration of sodium channel blockers to type 1 ST elevation. A medically induced elevation of ST segment of at least 0.2 millivolt makes a Brugada syndrome possible when the above named clinical criteria are available. But ST segment changes less than 0.2 millivolts are indefinite or unspecific. So let me run the Brugada syndrome type 1, type 2, type 3. You actually grade the type 1, type 2, type 3 based on the J amplitude, the T wave, the ST to T configuration, and the terminal ST segment. In type 1, the J wave, actually in type 1, type 2, and 3, the J wave are more than 0.2 millivolts. But in type 1, the T wave is negative. In type 2, the T wave is positive or maybe biphasic, and its type 3 is positive. In type 1, the ST segment is curved. In type 2 and type 3, it is saddleback. In type 1, the ST segment may be a bit depressed. In type 2, it is elevated above 0.1 millivolt, and in type 3, it is elevated below 0.1 millivolt. So, you actually decided to tell a young doctor in your clinic about the diagnosis you are thinking of, which actually interested him. He had heard of this name before, and he was actually interested. Your laboratory parameters were okay. CRP was light elevated 9 mg per dl. You had a leukocytosis of 13.4 thousand per liter and a small left shift. You decided now to take the history. What information would really interest you in the history you want to take from this patient? Well, I will ask check for history of frequent sudden deaths in the family. As for history of earlier syncopes, look for history of recurrent dizziness, pre-syncopal attack, arrhythmia, or fast heart rate. Ask if he had had ECG done before, and check the medication history. In the physical examination, you saw an acute ill patient. From the emergency protocol, you notice that the patient had a temperature of 39.8 degrees Celsius. The patient told you that there's no sudden death in his family. He does not take any medication, and he has not had any syncopes in the past. He has some dizziness sometimes, especially when he stands up from sitting or lying position. But his bodily exertion tolerance has been perfect, and there has not been any problem with his heart. He does not know if he doesn't have palpitations or exertional dyspnea, and concerning a previous ECG, he is not sure if he has had one because he does not have a house doctor. Due to his high fever disease and the reduced general condition, you admitted the patient. Do you need more tests for your decision? If yes, which one? Well, because the patient presently is suffering an acute fever infection, I would like to repeat the ECG and check for changes in interval. That is when the patient is fever-free. What principal thinking do you have, or what principal thoughts do you have for the further patient management in this case? I am really thinking if there's an indication to do an electrophysiological examination. I'm thinking if the patient will need an ICD implantation, and I'm thinking if the patient will need a medicated therapy. Okay, the suspected bacterial cause of the fever infection has been ruled out, and the patient was discharged 2 days out of the clinic without fever. The patient came to your clinic in the following week, and you did an ECG, a repeat ECG. So let me tell you what the ECG looks like. In the 12 canal ECG, you saw its regular sinus rhythm, indifferent to left axis, 87 per minute. There were no repolarization disturbances. That means there was complete regression of the repolarization disturbances you saw during the fever period. According to Antelokovic et al. 2005, fever has been known to be able to unmask the typical ECG changes of Brugada syndrome. But how far this affect the prognosis or can help in the judgment of the prognosis of the patient is not laid down. In this patient, after the end of the fever, they had a normal ECG, which means that spontaneous ECG changes were not seen in this patient after the fever. I have a schematic diagram here which I will run out to you, which will help you to know if you need an ICD or electrophysiologic examination or none in cases of suspected or Brugada syndrome type 1. If you have a spontaneous type 1 ECG Brugada syndrome, you need to know if it is symptomatic or asymptomatic. If it is symptomatic and you have history of a survived sudden heart death, that's a class 1 ICD indication, and we recommend an electrophysiologic examination to clarify if there is particular tachycardia. In those symptomatic patients without survived pleurotic heart death, if they are that syncope or seizures or central breathing disturbances, then you do evaluation to check if they are cardiac or non-cardiac causes. If they are cardiac causes, it is a class 1 indication for ICD and EPU, electrophysiologic examination. But if they are non-cardiac causes, in this patient with symptomatic type 1 that have seizures, syncope, and central respiratory disturbances, you need close follow-up. Those are the symptomatic ones of the patient with type 1 Brugada ECG. The asymptomatic ones, you need to know if there is a family history of sudden death through Brugada syndrome. If there is a positive history of sudden death in the family, you need to do an electrophysiologic examination, and if positive, ICD implantation. If negative, you need a close follow-up. Those asymptomatic patients with class 1 that have negative family history, you still need to do an EPU, and if positive, ICD. If negative, follow-up, close follow-up. So those we are talking about now, we are patients with spontaneous type 1 ECG changes of Brugada syndrome. Now let's go to induced type 1 ECG changes with sodium channel blockers. Then we have to know if they are symptomatic or asymptomatic, like we did in the above case. In this induced type 1 ECG Brugada ECG changes, the symptomatic ones like above that have survived a sudden heart death will need an ECG and later electrophysiologic examination. The symptomatic ones that have had syncope, seizures, or central respiratory disturbance, we need more evaluation to know if they have cardiac causes. If yes, they need ECG and electrophysiological ICD and electrophysiological examination. If no, they need close follow-up as above. In the asymptomatic patient, that is within the induced type 1 ECG Brugada syndrome with sodium channel blocker, in the asymptomatic, you look for family history like above. If there's a positive family history of sudden heart death, you do electrophysiologic examination as above. If possible, ICD. If negative, follow-up. Exactly like above. And those in the negative, the only difference now is the induced type 1 ECG. In the spontaneous one, even with negative family history, you need an EPU. But in the induced one, if there's no family history, you do not need to do an EPU. You need just this close follow-up. So let's go back to this your patient. You decided that, well, you have time to wait and watch, and the patient has to come back in 3 months to your clinic. You did not give any specific medicated therapy, but you warned your patient that in case he is given any medicine, you should always ask if these medicines can trigger a Brugada ECG, and if yes, he should avoid such medication. We also have advised him to avoid cocaine and alcohol intoxication. Thank you very much.